Yeah, thank you, Dr. Nitin. Thank you, Dr. Nitin, for the wonderful introduction. And today's session, we have specifically taking into consideration the various types of neurodevelopmental disorders, which we see across the clinical practice. So the purpose is not to discuss in detail about each and everything, but the purpose is to see how we can distinguish and differentiate different types of presentations of neurodevelopmental disorders, which may mimic one to another. So that is the whole purpose of today's discussion of the webinar. And there are around 30 cases which has been designed. And depending upon the time, because definitely there will be a time constraint. So depending upon the time, we'll try to cover as much as possible. So we'll give it maximum 1 minute, 15 seconds to each question. So I'll be going through the question and then we can take approximately 1 minute, and then accordingly we can discuss and you can put up the queries, what you think about the question. And then at the end of the session, if there is any doubts, we can discuss in a particular question or in general. So I'll just begin with the first case scenario. So this is the first case scenario. 7-year-old male child with no significant developmental history had recently shifted to a new place with parents. The mother discusses the problem with the doctor, mentioning his son has shown sudden loss of speech, language over the last few months. He doesn't respond to name or any instruction. We have also noticed a change in his behavior. He gets agitated and aggressive nowadays without any unknown reasons. When we try to ask him, he doesn't speak anything. Mother also notices some twitching movements of hands, mouth during sleep. He is often gets awake in the middle of the night. We are worried as we feel he might be missing his school friends. So doctor advises sleep EEG, which shows bilateral paroxysmal sleep activated paroxysms predominating over the temporal and temporoparietal regions with generalized sharp and slow wave discharges. So what is the best initial approach in this case? So, participants, you can go through the question and I request you can put up your answers on the chat box, and then after a minute, we can have a discussion on that. So there are 4 options which has been given. Refer to an SLP. As they have mentioned, there is a sudden loss of speech and language, which was present over the last few months. Then they have mentioned, should we give a trial of risperidone? Should we give a trial of steroids or trial of methylphenidate? So they have also mentioned that there is no significant developmental history. So anybody would like to discuss? Anybody would like to put up his comment on this question?
Sir, let's proceed. Most of the time, participants would like to be more participative in the later half.
No problem. So this is probably, see, this is a case of LKS, that is Lenoir-Cliffner syndrome. The reason which are favoring in this, first of all, the most important thing, EEG, which shows a typical pattern of bilateral paroxysmal sleep activated paroxysms predominating over the temporal and temporoparietal regions with sharp generalized waves. So this is a typical pattern of EEG in a LKS. Now, if we go into the history part, what are the things which are suggestive of that? First of all, they have mentioned that there is no significant developmental delay in the child. So first thing is clear that a 7-year-old child with no significant developmental history, probably it is unlikely to be associated with autism or any other thing. They have also mentioned that the child has shifted to a new place with the parents, and the mother discusses the problem that there is a sudden loss of speech language. Now, whenever there is a sudden loss of speech and language, there are 2 important DDs which we need to look into consideration. First and foremost is, as I have told you, LKS, because there has been associated sleep disturbances in this child. So whenever there is a history which suggests of sudden loss of speech in child, typically in an age criteria of 5 to 7 years or 5 to 9 years with sleeping disturbances, we always have to rule 2 important things. Either it can be an LKS or mute autism. Now, generally, a picture might also present with a regression autism, because many a times they might give you a history that child was absolutely normal without any development delay, but suddenly at the age of 3 to 4 years, he started losing speech. There was a lack of socialization skills. They started regression on speech, talk, and everything. But in case of regression autism, the typical age of regression will be somewhere around 3 to 5 years. But here, the age of presentation with regression of speech came out to be at the age of 7 years. So the most likely presentation is this child is LKS. So in an LKS, we always give us trial of steroids. So methylphenidate is ruled out from the picture because it doesn't fit into a criteria of ADHD. Risperidone, there are no features which are suggestive of behavioral issues. SLP, we might think, yes, we might give a child a trial of SLP because there is a speech and language, but taking into consideration the whole picture and everything, it is most likely an LKS. So we need to give a trial of steroid in this case. Definitely, along with steroids, supportive treatment is there, like refer to SLP and all those things. But the initial best approach would be in this child, considering LKS is a trial of steroids. So explanation, LKS is a rare condition which typically occurs between 5 to 9 years with sudden loss of speech and language with focal with generalized seizures during sleep. So that sleep disturbances could be a certain seizures which were presenting during the sleep. That is why he advised an EG and we got a picture in the EG. So there is a typical EG finding which we have discussed. So important DDs are regression autism and mute autism. But the core features of autism like sensory fixations, eye contact are always absent in LKS. So the regression of speech and language also do not coincide with the typical age of regression autism, which typically occurs between 2 to 4 years. So management, steroids, AD, and speech therapy. So the initial approach for this child would be a trial of steroids. So let's come to our next question. Reciprocal imitation, which is an important social skill for the development of children, is lacking in autism. In a child, reciprocal imitation can be picked up as early as 6 months, 9 months, 12 months, or 15 months. So what do we think that reciprocal imitation, which is a very important milestone, and we always talk about that imitation, joint attention, eye contact are always lacking in children. So they have mentioned that when a child you are in autism, there is imitation or reciprocal imitation is typically lacking. So at what age can be picked up as early as possible? Is it 6 months, 9 months, 12 months, or 15 months? Oh, okay. Some of them have mentioned 9 months. Some of them are telling 6 months. I got one more. Yeah. So So the confusion is between 6 and 9 months. Most of the responses which are coming is between 6 to 9 months. Now, 6 months is the correct answer because 6 months is the age which we typically get a reciprocal imitation a child imitates. What does reciprocal imitation means? Whenever you pick up a child at the age of 6 months and you keep on the lap, when a mother keeps a child on the lap and the mother gives him a smile, the child always gives back a smile. You typically observe this milestone in a 6-month-old child that will be definitely present in a normally developing child. But when you are suspecting autism, this typical imitation, reciprocal imitation will be lacking. The child might not be looking here and there. It will be bland. He might not give any look when the mother gives a smile. So that means to say that we can pick up the earliest sign of autism at the age of 6 months, which is reciprocal imitation. But if we go by the guidelines, at 6 months, we cannot give a screening. Even as per the American Academy of Pediatrics, they recommend screening of MCHAT should be done at 9 months, 12, 15 months. And definitive diagnosis, that is, we know that cards which has to be used at 18 months, this is the earliest stage. But the earliest sign can be picked up at 6 months. So 6 months is the right answer. So among the following early intervention strategies for ASD children, which one of the following is not child-centered approach? Pivotal response training, milieu training, that is naturalistic environmental training, discrete trial training, or none? So these are all the early intervention strategies which we apply for the ASD children. But out of them, one of them is not child-centered. Which one of them is? So when I talk about child-centered, there is one thing which we should know, that when I talk about child-centered means it should be in child's way. There should not be any rules and regulations. There should not be any formulation of guidelines. There should not be any formulation of guidelines. There should not be anything. Okay. So the answers which I'm getting, most of the answers which I'm getting is D. Answer is, they are mentioned none. Answer is C. C is discrete trial training. So discrete trial training is the right answer. The reason is because pivotal response training, naturalistic environment training, both of them are child-centered approach where we try to involve the child's interest in order to develop skills of various instructions and everything. For example, if a child loves to play with a car, especially with a red car, so we will, in pivotal response training, we will be going and favoring the red car in order to develop various skills in a child. So that means we are going in a child-centered approach. In whatever interest the child has, we are approaching that. Similarly, naturalistic environment training is also the similar thing compared to the pivotal response training. Whereas discrete trial training is not a child-centered approach. Discrete trial training is basically a method of giving an instruction and breaking the instructions into a simpler method. So discrete trial training means you are breaking a big step, like go to the kitchen. So a child on ASD might not be able to follow that command, go to the kitchen. So here we break this command into small steps. That is what we call as discrete trial training. And there are certain steps in this. So I'll show you the steps. So this is a discrete trial training. So discrete trial training means you are breaking, it's a method of giving instructions. Whereas those are not the method. They are types of child-centered therapies or child-centered forms of play. But here, this is not child-centered. It is a clear-cut method of breaking big step, big command into a smaller one. So there are certain steps have to be followed. Imagine I'm giving a command to the child, go to the kitchen and get a glass of water, or just go to the kitchen. Now, a child may not give you an eye contact. So the first and foremost thing is, most important thing is, you have to first develop an eye contact. Once the child gives you an eye contact, you give a command, go to the kitchen. Now, you have to wait for 30 seconds before the child responds. This is a clear-cut guideline which has been given by DTT, discrete trial training. Once you give a command, the first and foremost step is you have to take attention of the child. That means the eye contact. Once it gives you an eye contact, you immediately give a command, go to the kitchen. It should be clear, simple, and instructive, depending upon the ability of the child to understand. And once the child gives an eye contact, you follow the command. You have to wait for 30 seconds for the child to respond. If the child follows towards that direction of the kitchen, then you start giving him a prompt. Either it can be a visual, it can be a verbal, or it can be a gestural. And once he completes the task, that is reaches the kitchen, you deliver it with a reinforcement, that is reward. So this is a typical step which we follow in a discrete trial training. Now, for example, if you give a command, the child doesn't respond to your command for 30 seconds. Then you have to repeat this command again. Normally what happens, we give a command, go to the kitchen. We wait for 5 seconds, 10 seconds. Again, we give a command, go to the kitchen. That is a wrong approach. We have to wait for 30 seconds and then judge the child whether he responds, because this is the time we have to give the child to process the command. So I hope this is clear. So the answer is DTT, discrete trial training. Then coming to the next question, autistic kids have poor prognosis compared to ADHD kids. The possible explanation could be, in autism, there is undersynaptic pruning, there is delayed synaptic pruning, there is excess synaptic pruning, or comorbidities associated with ADHD are less severe compared to autistic kids. So we know that definitely ADHD and autistic kids, if we come in the early phase, definitely by the age they reach to the adolescence, somewhere around 13 to 15 years, ADHD kids have better prognosis generally compared to autistic kids. But whereas if we talk about the autistic kids, they will have definitely poor prognosis. So what could be the possible explanation that why they have better prognosis? Okay, so I'm getting all the answers A, B, C, D. So the correct answer, just a minute, I'm getting two more options. Okay, so I'm getting all the answers A, B, C, D. Now, one thing it has to be very clear. In autism, there is delayed synaptic pruning. Sorry, in autism, there is under synaptic pruning. Under synaptic pruning means there is a deficiency of synaptic pruning. Whereas in ADHD, there is delayed synaptic pruning. Now, what is synaptic pruning? I'll show you in the next slide the correct explanation. What does synaptic pruning means? We know that pruning is a process where there is unwanted connections of neurons and everything. They gets wind off, or means unwanted connections of neurons, they get replaced, and this process happens so that the further logical thinking and activities improve. And when a child is born, there are a lot of unwanted connections are there, or what we call in terms of diagram, that is there is a thickness of cortical thickness is less compared to ADHD, whereas in autism it is more. When we talk about cortical thickness, when we do an MRI, definitely these changes we get. Other than this, we might not get any other thing. But if I come about at the biological level to discuss this, it means to say that when a child is born, a newborn is born, there are a lot of unwanted connections which are there. And by the age of 3 to 5 years, this process of synaptic pruning happens. That means unwanted connections are removed. And this typically process happens with the help of phagocytes, or which are considered to be the brain phagocytotic cells, which are known as microglial cells. And this is the typical function of the microglial cell which causes the synaptic pruning. Whereas in autism, there is under synaptic pruning, means the unwanted branches of the tree, they are not being cut off at all. That means they remain as it is. As a result, when a command is given to a child, that command will follow all those synaptic connections. As a result, it gets confused. Even a simple command, go to the kitchen, might give him a sensory overload because it is traveling from so many synaptic connections. Whereas when you talk about an ADHD kid, there are so many branches of synaptic connections are there, but there is a delay. That means synaptic pruning happens, but it happens at a delayed age. It should happen at the age of 5 to 6 years, but it happens at the age of 10 years and 11 years. And probably this is the reason that when the ADHD child goes in a state of adolescence, passes the adolescence, it has better prognosis, logical thinking, understanding, and high mental functions are better compared to autistic kids. So the correct answer is because in autism, there is under synaptic pruning. So this is a typical diagram. This is a normal brain functioning. When I go to the autistic, there is a decreased synaptic pruning. Decrease means it happens, but it happens less. Under. Delayed means it is happening. It is suppose 90% of the neurons have to remove. They are happening, but they are happening at an age, maybe with at a delayed age. It should happen at the age of 3 to 5 years, but it is happening at the age of 11 years. But it is happening. That is why the prognosis of ADHD kids are better in an adolescence compared to an autistic kids. Now let's go to the next question. A 6-year-old male child with need-based speech with average IQ. So they have mentioned need-based speech with an average IQ. Mother complains to the doctor that he is always fidgeting in class, running, pushing, and disturbing other kids. He always screams as soon as he enters the school gate. So these are all the complaints which the mother is telling. This has increased over a period of time in school, and mother is very worried. So all those fidgeting, running, pushing, disturbing, screaming in the school once he enters the gate. So all those things are disturbing the mother a lot. Mother says child is cooperative with doing tasks at home, doesn't show such behaviors at home. So what is the least likely condition associated with the child? So very important thing is the child is showing all sorts of behaviors in school. Mother is very worried. School management is complaining, but the mother, to the contradictory, says that child is cooperative and doing tasks at home, and he doesn't show all those behaviors in home. So what is the least likely diagnosis, which is condition, is associated with the child? Is it an ADHD? Is it behavioral issues? Is it auditory sensory issues? It is an autism spectrum disorder. So please read this. I am mentioning what is the least likely diagnosis. Okay. So okay, see, I'm getting all the answers B, C, D, but I'm not getting the A. Now, let me revise the DSM-5 criteria. Now, what does the DSM-5 criteria for ADHD says? We know that there are two important things which has to be present: impulsivity and hyperactivity. These which is very, very much clear. But the most important thing with DSM mentions, DSM-5, that these symptoms of ADHD or these peculiar features of ADHD, that is impulsivity and hyperactivity, should be present in two or more settings. This is very, very important. It should be present in two or more settings. Now here, the one setting is school and the other setting is home. In the first setting, that is school, he is showing all features of impulsivity and hyperactivity, no doubt. But does the child showing similar features of hyperactive impulsivity at home? Answer is no, because mother clearly says he is cooperative and not doing task at home. Doesn't show any such behaviors. So the criteria of impulsivity and hyperactivity is fulfilling only in one setting. It is not being fulfilled in the next setting, that is the home. So here DSM-5 criteria for ADHD doesn't fulfill. Now, if I talk about behavioral issues, definitely the child might be having behavioral issues. We don't know, because as per this history which has been given, he is showing behavioral issues, which can be like in the form of running, pushing, disturbing another kid, screaming. It might be auditory sensitivity issues, clearly, because he's screaming. There might be a lot of noise from the school. There might be sound of the school gate. There might be ringing of the bells, which might be causing a lot of sensory processing issues. It could be an autism spectrum disorder. Definitely, the things which is mentioning, it could be an autism spectrum. No doubt, we know that ASD might comorbid with ADHD. We don't know, or it might be a simple hyperactivity. It might be a sensory meltdown. So picture is fitting onto all this, but at one look, it appears to be an ADHD, but it doesn't fit into the criteria for DSM-5 to be fulfilled in two settings. So the answer is ADHD. So the least likely diagnosis associated with the child is ADHD. I hope I have made myself clear in this. So the least likely possibility is ADHD, though the child is showing features of hyperactivity, but only in one setting. That is what exactly I told you. The child, it has to be as per DSM-5, the criteria should be filled in two or more settings. So in the home, there is no such features. Rest of the features like running might be a vestibular seeker, touching, hitting might be a tactile or behavioral issues, could be a part of sensory involvement. Hence, ADHD is the best option among the above. So next come to our next question. This is about the disability. That is the disability certificate, which has now been introduced by the government of India, and people on autism can get a disability certificate or cannot get a disability certificate. Let's discuss this question. So a 4-year-old male child with features of autism, not showing eye contact, poor response to call name and delayed speech and poor imitation skills. So all core features of autism are being present in this child. The child is on various therapies. The therapists advise the parents to get the disability certificate, as this will benefit the child in long term. So the child was assessed by a team of multidisciplinary team comprising of pediatrician, clinical psychologist and psychiatrist. The score of ISA, that is Indian Scale of Childhood Autism, the score of ISA came out to be 85. The IQ of the child is 87. The disability certificate will be issued with the following remarks: mild autism with 40% disability, mild autism with 50% disability, moderate autism with 40% disability. Child is not eligible for disability certificate. So what are your thoughts on this question? Okay. See, first of all, we should know that what is the scoring of ISA. So let's go to the scoring of ISA. So this is the scoring of ISA. I hope it is clear. On the score of ISA, if it is less than 70, the child is normal. If it is 7 to 106, it is mild autism. It is 107 to 53, it is moderate autism. And if it is more than 53, it is severe autism. So what was the score? The score of ISA is 85. So that means as per the ISA score, the child comes out to be in the category of mild autism. So one thing is clear, the child is in mild autism. So it can be either A or B. C is ruled out. That is one thing. And D we need to look out. So A and B are the two options which are left. Mild autism is definite, but whether it is 40 or 50% disability, let's see the IQ. The IQ is 87. So irrespective of the IQ, ISA gives you the percentage of disability. So percentage of disability upon the depending upon the score of ESA. So on score of 70, you get a disability of 40%. On score of 71 to 88, you get a disability of 50%. So the child is having ESA. The child is having a ESA score of 85. So 85 means that the child is having a disability of 50%. So the answer should be mild autism with 50% disability. But one thing is a catch here in this question is, in India, as per the GOI, Government of India, a child is not eligible for the disability certificate, particularly for ASD, unless and until he has reached the age of 5 years. This is a very, very important thing which we should note, that at the age of 5 years, a child is eligible for a disability certificate, but that will be issued as a temporary disability, which will be revised at the age of 10 years and 18 years. At the 18 years, you get a permanent, but till the age of 18 years, the child is not achieved, you will get a temporary disability. So many a times parent comes up, what is this temporary? It's a lifelong disability. So what does that mean temporary? It means it has to be renewed at the age of 8, 10 years and 18 years. So these are the revised guidelines which has been given by Government of India, which should be very, very important to understand this, because many a times you might get patients at your clinic that, sir, we are eligible for we want a disability certificate. Most important thing, you should know the age of the child. If it is below 5 years, he will not be eligible for a disability certificate. So in this question, I have mentioned the age of 4. So right now he is not eligible for a disability certificate. Probably in the next year, he will be eligible depending upon the score of ESA. So irrespective of the IQ, now a child can get a disability certificate. Earlier till 2012, a child for autism in India was not eligible for disability certificate unless and until he has an IQ of less than 70. That means with autism, he should have an intellectual impairment, because an IQ less than 70 fulfills the criteria for intellectual impairment. That was till 2012 to 2014. But now the guidelines have changed. It is totally on the basis of ESA score, irrespective of the IQ, but age is important criteria. So now let's come to the next question. So a 9-year-old girl, I hope I'm not running fast. Dr. Nitin, is it okay? I think Dr. Nitin is not here. Okay, so let's go to the next question. So a 9-year-old girl is brought to the clinic for chronic irritability. Her parents report temper outbursts that are difficult to control, extremely frequent, and apparently out of proportion to a particular situation. So these symptoms have been present for more than 1 year and in 3 different settings. The appropriate diagnosis is made and various behavioral modification techniques are suggested, including positive punishment. So which of the following best describes an example of this techniques? Means to say, which of the following best describes an example of positive punishment? When she stays out for an hour past a curfew, her parents ground her for 2 weeks. So whenever this child goes out and in a curfew, her parents ground her for 2 weeks. This is a type of punishment they are giving. When she fights with another student in the class, the teacher gives a frowning face stickers on a progress board. So this is another type of punishment which the teacher gives. When she fights with a sibling, when the fight with the sibling gets over and gets to play the video game, the father takes the video game away from both the children. So when she fights with a sibling for the video game, what does the father do? The father takes away the video game from both of them so that the quarrel settles. And after a cell phone rings in the middle of the chemistry class, she is ignored by the teacher for not turning off the phone before the class. So another type of behavior she shows, that in the class, nowadays, at 9 years, children are carrying cell phones. So I mentioned that cell phone question. So at the 9 years, when in the chemistry class, when the cell phone rings, the teacher ignores that completely, so that she might not do that again. So I want that, what is out of these 4 options, which one explains the technique of positive punishment in this case? If anyone can write whatever thought is coming in your mind, you can just write and chat on it, so that it will be, it will be good for all of us to interact. I think this question, it was also put up in the group. So if anyone was, active during these questions, which was being sent by Dr. Nitin in the group, so probably they might know the answer. Okay, so let's discuss each of the questions. So when she in option A, when she stays out for an hour before curfew, your parents ground her for 2 weeks. So first and foremost thing is we need to understand what is positive punishment and what is negative punishment. A child is showing a child is showing a desire A, and I have put some input into the child so that he gets a desired behavior which I want. A desired behavior is C. So A plus I have given an input and I get a desired behavior C which I wanted. So that means I have given some input, positive input. So this is positive reinforcement because A plus positive reinforcement, I wanted a desired behavior which is C. But suppose A minus something, I have taken something from the behavior. I wanted to put some desired behavior. So I have taken out some input. I have taken out some aspect, something from the child in order to get a desired behavior that is C. So that means I'm taking out something. So that is called as a negative reinforcement. That means taking out something from a particular scenario in order to achieve a positive or desired behavior is known as negative reinforcement. Adding a something to the present behavior in order to get a desired behavior is positive punishment or positive reinforcement. So here in this child, what do you think? See, if I go in first, when she stays out for an hour curfew, her parents ground her for 2 weeks. So there is nothing which shows that they are doing adding something in order to get a positive. We are not getting anything with this. When she fights with another student in the class, the teacher gives a frowning face stickers on a progress board. So when she fights with a student in the class, so this is a behavior, present behavior. The teacher adds some input into his mark so that he gives a better behavior. So he's adding something. So here a positive recruitment or a positive reinforcement is given to the child. So yes, option B could be an option. Let's go on option C. When she fights with the other sibling for the video game, the father takes away. So he's removing the input. So he's taking out something that is definitely not a positive reinforcement. In D, there is no such positive and negative. He's just ignoring that. So attention seeking behavior with the teacher is ignoring it. So that typically fits into the criteria of attention seeking or attention ignoring. So here the correct answer is B, because he's adding some input into the child's record so that he doesn't show this present behavior and shows a possible desired behavior which we want. So the correct answer here is B. Okay, so now this is the slide. Yeah, so this is an example which I was telling you. When you so positive reinforcement means increases the frequency of desirable behavior when you add some positive stimulus to the child. So when a stimulus is being added to get a positive behavior, it is known as positive punishment or positive reinforcement, means that something is being added. Whereas when you remove something, removal of the stimulus in order to get a desired behavior is known as negative punishment or a negative reinforcer. That means you are removing something. So that is what the answer is. Answer is B here, positive. So let's come to the next question. A 5-year-old female child goes to the doctor with parents complaining of poor academic performance. She doesn't sit in one class at one place, keeps on moving from one seat to another, causing disturbance in the class, but her reading skills are excellent. Her reading skills are excellent. There are issues with writing, especially grammatical errors. For example, she writes, I'm going to school rather than I'm school to going. So instead of writing, I'm going to school. So there are grammatical errors. Instead of writing, I'm going to school, she writes as I'm school to going. The mother says similar problem she has noticed in home also while writing. But she is cooperative, but she cooperates well in doing tasks at home. She doesn't communicate much with friends, but can respond to direct questions. So what is the possible diagnosis to this child? So dyslexia, is it dyslexia? Is it social communication disorder? Is it an ADHD? Is it an ADHD with dyslexia? So most of the option which I am getting is A and most of the option which I am getting is A and D. This is a typo error. It is D. So most of the option which I am getting is A and D. Now, one thing is very, very important. Whenever we talk about dyslexia, there are two things which has to be noted down. The child doesn't have phonic awareness. Second thing, because of the lack of phonic awareness, the child doesn't have that phonic memorization also. For example, instead of cat, he reads at bat because there is no phonic awareness of ka. So that ka will come as ba. Secondly, when he reads the complete, that is phonemes, when we join together, call as phonomic word joining, that is the whole word. Lexicon, which we call phonemes, is ba, ka. When the word is joined, like ba, ta, bat, so this whole is known as lexicon. So there is a lack of lexicon awareness and what we call phonic awareness. As a result, the child who is on dyslexia will read cat as bat or hat as cat because he cannot visualize the ka sound, and secondly he cannot memorize the ka. To read and to look on the blackboard and read also requires some memorization of that word from the board. It is very simple to say, but it is very difficult when a child on dyslexia is having that. So here there are no such things because they will be definitely reading issues, but her reading skills are excellent. The first and foremost thing is again, there are spelling mistakes are there in a child with dyslexia. When we talk, because there are phonic awareness issues, there is lexicon awareness issues. So as a result, there will be spelling mistakes. Here, I have mentioned you that he's writing, I'm school to going rather than I'm writing, I'm going to school. So there is a typical grammatical error in this child, whereas his spellings of school going is absolutely fine. Another thing is, she cooperates well in doing task at home. He has noticed problems in writing, the problems in writing in grammatical errors. So there are typical pragmatic errors, but she cooperates well in doing tasks at home. She doesn't communicate. Now, a child on dyslexia might have issues with communication, but will not have issues, but will have issues with writing and reading. This child has good, excellent reading skills. Writing is also good, but the problem is with the pragmatics. Problem is with the grammatical errors. Also, the important thing is she doesn't communicate much with friends because he has pragmatic issues. He cannot speak the right formation of the sentence. Pragmatic means the formation of the sentence should be in the right form. The pen is on the table. He might say table on the pen. So that is what we call pragmatic. So as a result, she doesn't communicate much with the friends, but he can respond to direct questions. What is your name? Ba. What is your name? Ka. X, Y, Z, he can answer because there is no formation of pragmatics. So here, the right answer is social communication disorder. Sensory issues in a social communication disorder will definitely be there if we go about by the DSM-5 criteria. All the features of sensory issues X, Y, Z will be present in a child because, but it will, the core features of autism will not be there. There are no core features of autism, but there are features of pragmatic which are typically associated with SCD, and SCD is a very important differential diagnosis for a speech and language delay child, for an isolated speech language delay child, and for a dyslexia. So this case is not a case of dyslexia, it's a case of social communication disorder. ADHD doesn't fit into the criteria at all. So now the next question is 8-year-old male child on autism. It's showing excessive behavioral issues in class. So there are excessive behavioral issues. He's on autism. This is diagnosed. So teachers are complaining that he always starts throwing things and screams after every period when the bell rings. After every period when the bell rings, he starts throwing things. The school special educator has tried various behavioral interventions, but they were not able to tackle the behavior at all. In such a case, the best initial step to modify the behavior is look for antecedent factors, target the difficult behavior with positive reinforcement, target the difficult behavior with negative reinforcement, avoid the behavior. So what do you think would be the best possible option in this case? It's a question typically on the behavioral issues. We see a lot of behavioral issues in autism child. Yeah, just you can. There's a one thing I want to mention in this question. One participant has mentioned that doesn't communicate, doesn't explain clearly that it is a SCD. Definitely, but the thing which is explaining and giving a giving a probable diagnosis and more favorable diagnosis for SCD is the pragmatic issues which he is having. The pragmatic issues, the grammatical errors which the child is showing typically in writing. It is a typical feature of an SCD child. I have mentioned the best initial step. The initial step, what is there? So the correct answer is this child. So an initial step cannot be two. It has to be only one. So one participant has mentioned some two options. So out of this, it has to be one only. So the correct option in this case is answer A. We always have to look for antecedent factors. So why? Because in any behavioral management, we always follow a process of ABC. Airway, breathing, circulation. No, this is not for PICU. This Dr. Nitin will tell. ABC means antecedent, looking for an antecedent behavior. Looking for an antecedent means looking for an anticipatory factor which is causing B, that is behavior. C is consequence. So whenever we are tackling a behavior in a child with development delays or neurodevelopmental disorders, we always have to follow a path of ABC. A means look for the antecedent factors which are causing or triggering the behavior. B is the behavior. Then you approach the target. Target that behavior. First, you need to look into the antecedent. Now here, suppose a child is having a lot of stomach in the pain. He screams. The teacher comes, why are you shouting? He throws him out of the class. So he's targeting the behavior directly because he's shouting, so he throws. But he doesn't know the child on autism might not be able to express his needs. So that is why he's throwing things, because he's having pain. So you need to look into the factor, what is the antecedent or the preceding factor. Then only you target the behavior, followed by the consequence, what you want to give. So here the correct answer is A, look for the antecedent factors. A 6-year-old male child, it is again on the behavior. A 6-year-old girl is brought to the clinic for chronic irritability. Her parents report temper outbursts that are difficult to control, extremely frequent, and apparently out of proportion to a particular situation, particularly while giving bath in shower in winter. So mother says that these symptoms have been present over the more than 3 months. So mother says whenever she is giving a shower to the child in the winters, he throws a lot of outbursts, tantrums, and all sorts of behaviors. The mother tried all sorts of calming techniques, but the child behavior increases during the bathing time. So it's a typical scenario which is happening. One day, mother reduced the intensity of the hot water in shower, and child took the bath very comfortably with minimal behavior. So this is an example of which type of behavior management. I hope it's a very clear-cut options I have given: positive reinforcement, negative reinforcement, attention seeking, or escape or avoidance behavior. Okay. At one go, everyone has mentioned answer D. Option D is not the right answer. Option B is the right answer. If you go clearly and little carefully in this question, as I mentioned also, when we talk about positive and negative reinforcement, positive means you are removing positive means you are adding a stimulus to get a desired behavior. Negative reinforcement means you are removing a stimulus to get a desired behavior, though it may happen accidentally or deliberately. In this case, mother was giving a hot bath to the child with some intensity of hot water, and the child was screaming, shouting. Probably he was not able to explain that the intensity of the hot water is not comfortable to him. Probably he might be having sensory issues or tactile issues, XYZ reasons. So one day mother was not noticing, but probably because that intensity of hot water may be good for other family members. But the child on spectrum or XYZ throwing tantrums might be having those intensity. Irrespective of the autism, he might not be comfortable, though he might not be able to explain that. So one day mother reduced that intensity of the hot water. So that means he's reducing the stimulus. He's removing the stimulus from a particular situation in order to get a desired behavior. So mother reduced the intensity of hot water and the child behavior reduced. It became better. So it's an example of negative reinforcement. I hope I have made myself clear in this. So this is what I have explained, negative and positive reinforcement. So negative reinforcement never means that we are getting a negative behavior from the child. It's a misnomer. It means that you are getting a desired behavior by removing some stimulus from there. Now let's come to the next question. A 3-year-old male child with history of developmental delay comes with the parents for the routine follow-up. So a 3-year-old child with a history of developmental delay, point to be noted. The mother states he started walking at 16 months of age. We know that the target age of walking is 18 months, so probably it's within the range, and can pick up throw a ball. He can walk up and down the stairs. He can scribble. A 3-year-old child, he can scribble with crayons, stack of 6 blocks, and draw a horizontal line, but cannot copy a circle. He began using single word by the age of 2 and is now able to combine 2 words. He can identify 4 body parts and can identify objects in a book. He follows one-step commands, imitate adults, can turn book pages all at once. Impairment of which of the following major domain is most likely cause of his developmental delay? Visual motor integration development, emotional development, motor development, social development. So here's a case of 3-year-old male child. He started walking in 6 months. Now he's 3 years. He does scribbling with crayons, stack of 6 blocks. Important thing, he cannot copy a circle. It's not about it cannot copy a circle, but as per the age wise in social, he's gained by 2 words. He's now able to combine those words. He can imitate. He can turn the pages. So what do you think is the delay in which major domain in this child? Yes, absolutely. Most of our yes, most of our colleagues have answered the right. This is a visual motor integration. Now, VMI is a very important thing which is typically lacking in children in cases of development delay. That means to say they might write a dictation, but when it comes to copying, it becomes a difficult because visual motor integration is a part where we have to visualize, and then you have to visualize, then you have to memorize, and then you have to copy. So that whole parts form of visual motor integration. That is a typical thing which is happening in the children on learning disabilities. Exactly what I was explaining you some 2-3 slides before. That is awareness and memorization. And we know that many children on autism definitely have under umbrella of learning disability. Though we do not get a clear isolated dyslexia, but they are definitely have learning disabilities. So this is an example of visual motor integration development. There is a delay in this child, or you can say it's a cognitive developmental delay. So the patient, so we have explained and most of them have marked you the right, most of them have told the right answer. So let's go to the next question. So 15-month-old male child, it's a 15-month-old male child comes to the doctor with delayed speech. Mother says her first words came at 9 months. So mother ne bola his first word came at 9 months, and then after there has been no progression of speech. Only ma came at 9 months, then there was no progression. She admits her screen time was more than 5 hours a day. So the child was watching 5 hours a day screen time, but now it has been reduced to 2 hours per day. As per a mother, her understanding skills are average, can indicate some of her daily needs, and she is not toilet trained. So 15 months is not toilet trained. She likes to play with her elder brother, likes peekaboo. Developmentally, mother feels she is at par except speech. She can scribble on paper. The initial best approach for this child would be okay. See again. Uh, so I am getting all the options except B. I am getting all the 3 options A, C, D. All the options look right. See, the thing is, it's a 15-month-old child with a development. So here the most important things, the things which are there is a 15-month-old child with a delayed speech. Right now, she's only at the level of mama. Nothing else there has been no progression. Another important here is she was at 5 hours daily, but now it has been reduced to 2 hours. In spite of that, her speech, there has been no progression of speech. She is not toilet trained. Mother feels that there is some delay in relation to speech. Other than that, she's fine. She can scribble on paper. She plays peekaboo. It's a very good, important milestone. She plays a peekaboo with the child. She can scribble, an important milestone which should be achieved at the age of 15 months of scribbling, which is also there. So what is the best initial approach? The best initial approach is CARS and ESA is not there. This is not the best approach because first of all, CARS and ESA is a confirmatory diagnosis which has to be done at the age of 18 months. If I would have mentioned here MChat revise, that could be a possible option to think. So A is not the answer. Counsel the parents and tell she will speak as she is a late talker. No, definitely not. That doesn't fit into this child, that you cannot counsel a child that at 15 months, from 9 months to 15, there has been no progression. Enroll in peer play small groups and review after 3 months. It could have been an option, but the problem is mother typically says her understanding skills are average, can indicate some of her daily needs. So mother is still on a doubt. There are understanding, receptive skills are average. And mother also says that she feels the child is at par except speech. So speech is somewhere a problem for this child. Mother also feels that somewhere she is lacking on the part of toilet train and understanding skills are average. So two important things. Understanding skills are average. So she can indicate some of her daily needs. She cannot indicate all of the needs. So probably the right approach and the right option for this child is you have to do reels. That is receptive and expressive language assessment. If on receptive and expressive language assessment, the receptive skills also comes out to be low, then definitely another parameters, then we can go for MChat, that is screener, or we may go for a ESA or CARS at the age of 18 months. So definitely enroll in a peer play is not the right option. Enroll in a peer play would have been a right option if mother would have told understanding skills are excellent. She can indicate all of her daily needs, but she doesn't speak. You got my point. So here the expressive speech is definitely lacking, but it could be an associated receptive speech, which is not very much clear that it is good. So that is why we need to go for a reels receptive and expressive language test in this child. So next, let's come to the next question. A 4-year-old male child with moderate or spectrum or autism spectrum. So is a child with moderate ASD. It comes to the clinician with mother. So and mother says that there is a complaint sleepy very late night. The child sleeps very late in the night. It sometimes takes 2 to 3 hours to make him sleep. So he's on autism spectrum disorder with sleeping issues. It takes a lot of time for him to sleep. Sometimes he gets up around 1 a.m. and sometimes he wakes up around early morning, but usually sleeps at 8 to 9 a.m. Usually sleeps till 8 to 9 a.m. As a result of his health is deteriorating, mother health. She also gives history of frequent constipation and sometimes bloating to the child. The mother feels his immunity is low as he has history of frequent bouts of seasonal cough and cold. The child also has a habit of taking frequent daytime naps before going to therapies in evening. So there is a history of frequent daytime naps. The mother also tells he is on casein-free diet. What is the most appropriate first step? So important thing I mentioned, first step in approaching to this child in sleeping problems. So just to summarize, this is a child on moderate ASD with a lot of sleeping issues, and he has a history of gut issues. Mother feels immunity is low. There is a history of frequent seasonal cough and cold, constipation issues, but he also takes a lot of naps in the daytime. And so he's on some special diet. So mother feels, so comes to the doctor. So what does the clinician advise? What is the best approach in this child? I'm not saying the best approach. I'm saying what is the first. It could not be the best, but what is the first? X-ray soft tissue neck to rule out adenoids. Initiate melatonin in a low dose as it is the safest hormonal therapy for sleep issues in autism. Ask parents to prepare a diary of 24-hour sleep pattern of the child. X-ray rect abdomen to check out fecolis and start infraction dose of PEG followed by maintenance. EG to roll out subtle or silent seizures. Okay. So again, I'm getting all the options A, B, C, D. So here the right option is C. Ask the parents to prepare a diary of 24-hour sleep pattern of the child. The reason why it is there, because whenever we talk about sleeping, because sleeping issues is a very major concern in children with autism spectrum disorder. So now let's revise the NICE guidelines. So as per the NICE guidelines in managing sleep issues in autism, as per the NICE guideline, the first and foremost step is taking a detailed sleep history from the parent related to his triggers, frequent duration, daytime and bedtime issues. The history is commonly evaluated using Bayes tool. This is the Bayes tool. It is a parent-centered and even the child-centered. If a child is small, you can directly go for the parent. So associated medical problems like adenoid, gut issues and etc. common comorbidities which need to be evaluated and managed accordingly. But pharmacological approach, that is melatonin, has to be reserved only when the above approach fails. So this is a screening tool for monitoring sleep issues in children with autism. So you need to rule out this bedtime problem, excessive daytime sleep. So a child is having a lot of sleep issues in this because he was taking a lot of excessive daytime sleep. So the first and foremost thing is you have to regularize his sleep pattern. You have to regularize his sleep circadian rhythm. You have to regularize his sleep hygiene. Once you monitor, once you manage all these things, in spite of that, and then you have to work on the associated comorbidities like adenoids, X-ray, rectal abdomen. Definitely the answers which you have mentioned all the are the correct. But what is the first step? The first step is you take to maintain a daily 24-hour rhythm, because here the child is also taking a daytime nap. So you need to check what is his pattern of sleep and everything. Once that is worked out, once you maintain a sleep hygiene, once you cut down the daytime nap, then you figure it out, and then you go on to the step B, that is constipation and associated adenoids and etc. So the first step is 24-hour sleep diary. So this is as per the NICE guidelines which has been taken. So now let's come to the next question. Which of the following statement is not true regarding social communication disorder? So it's a very straightforward question related to SCD. It's a new diagnosis, so commonly mimics ASD but doesn't come under ASD as per DSM-5. It predominantly associated with pragmatic issues and less with syntax issues. It's a new diagnosis which has now been included under DSM-4 and doesn't come under ASD. It is a common DD for specific language impairment. So which of the following is not true? Anybody would like to give an answer on this? Okay, I'm getting all the options 1, 2, 3, 4. So social communication order, first and foremost thing is it was not present in DSM-4. Social communication has now been included only in DSM-5, which is the latest, that is around 2018, I think, or 17 or 18, it has been included. So as SCD is now been included in DSM-5. So one thing is clear, that commonly doesn't come under ASD as per DSM-5. So this is right, because SCD is a separate diagnosis, it doesn't come under DSM-5. So first option is correct. It is associated with pragmatic issues, as I was telling, that is also absolutely fine. It's a common DD for specific language impairment, that is also correct. It is a new diagnosis which has now been included in DSM-4. That is absolutely wrong, because in DSM-4, SCD was not there. It has included in DSM-5. So the correct option is, the wrong option is, it is not a new diagnosis. It is a new diagnosis which has been included in DSM. It doesn't come under ASD. That is wrong. It is under DSM-5. So third is the option. Third is the right answer. So let's go to the next question. 17-month-old child accompanied by parents, 17-month-old child. Their concerns are he has not started speaking words, just say ma, ba, time, sometimes, no speech on demand. He has an elder sister, enjoys cuddling, pretend play, can identify family members. Both parents are working, hence child remains with grandparents. Parents admit that his screen time is around 6 hours per day. He started walking at the age of 11 months. Mother says he can express his needs by gestures and points towards things of his interest. But he shows tantrums a lot, especially with father when his demands are not met. The initial first step in managing this child. Reduce screen time to 0 and recess after 3 months. Do ESA and CARS to rule out autism. refer SLP and start speech therapy, indulge in small peer groups. So what could be the best option in this? Yes, absolutely. No, some have mentioned that C. C is not the right answer. Again, the first initial step is because it could be a picture mimicking virtual autism. There are no features suggestive of actual autism because he can fulfill his need by gestures and points. Points toward things is a very important marker. Pointing is a very important marker. He enjoys pretend play, which typically happens at the age of 15 to 18 months. He enjoys cuddling. There is no speech on demand, but he enjoys cuddling. He can recognize parents. His screen time is very, very high. So the first and foremost thing is you have to cut down the factor which is causing, could be a virtual autism. So you have to cut down the screen time to 0 and reassess after 3 months. So we don't have to directly go to an SLP. We don't directly go to the CARS autism because there is no picture suggestive of true autism. It could be a virtual autism because he points, he gives gestures, he pretends play. These are very, very important markers which gives you an indication it is unlikely to be a true autism. So the right answer is you reduce screen time to 0 and reassess after 3 months. So let's come to the next question. This is a question on ADHD. An 8-year-old male child with a case of ADHD is on methylphenidate tablet 5 mg thrice daily. He's been taking this tablet since last 7 months, but mother has noticed that this medicine is not effective now much. He has developed a lot of sleeping issues. His inattention and hyperactivity has increased a lot. The child was not taking any therapies. It becomes very difficult to send him school. Lots of complaints are coming daily from the school regarding his behaviors in classroom. What is the next ideal approach for this child? Shift to methylphenidate prolonged release tablet 18 mg once daily. He was on 5 mg. Shift to methylphenidate prolonged release 18 mg 36 mg once daily. Increase the dose to 10 mg thrice daily. Shift to methylphenidate prolonged release 18 mg tablet plus behavioral therapy. Shift to methylphenidate prolonged release 36 mg plus behavioral therapy. So what could be the right answer in this? So he's an 8-year-old male child, he was not taking any therapies right now. He was not on any therapies. So he was just on 5 mg. Now he's 8 years. So what is the best option? Because on 5 mg, he's not been managing. So the right option here is D. We should shift to the prolonged release. Initially, he was on a methylphenidate, which was a stat release. He was not on sustained or prolonged release. So we should shift because here the effect of this drug is long. We know that methylphenidate hardly lasts for 5 to 6 hours. Here in sustained release, the dosage which has to be given is much better. So the answer is prolonged release 18 mg. That is true. But why it's behavioral therapy should be there. So let's come to the guidelines on behavioral therapy and ADHD. These guidelines have been taken as per the American Academy of Pediatrics. So less than 6 years, there is no role of medications. Between 6 to 12 years, there is a role of medications. You have to start with CNS stimulants, methylphenidate. If the child is not maintaining on methylphenidate, okay, then you have to go for the behavioral therapy along with the behavioral therapy. So here the child was on methylphenidate, but he was not maintaining. So along with methylphenidate, you have to go for the behavioral therapy. Grade C, that means poor evidence. There is no role of non-CNS stimulants like atomoxetine. So the child fits into the criteria of 6 to 12 years who was initially on methylphenidate, which was not benefiting. So step 1 has been ruled out. So then we have to go to the step 2. That means you have to role of CNS stimulants with behavioral therapy, and which gives you the grade A evidence is there. So in child between 6 to 12 years, role of methylphenidate plus behavioral therapy has the best evidence or has the best grade A level of evidence. Whereas only the role of CNS stimulants has grade B. So and no role of CNS stimulants. So above 12 years, you can grade A is you can try CNS stimulants, grade A, then non-CNS stimulants, grade B with behavioral therapy. So these are the levels of grades. So as per the evidence-based guidelines, the correct answer for this child is because he is above 6 years and fits into the criteria 6 to 12 years, methylphenidate sustained release with behavioral therapy is the right answer. And these are the doses. For 5 mg, 3 times a daily, we can switch to 18 mg. 10 mg methylphenidate, we can switch to 36 mg. So he was taking on 5 mg, we can switch to 18 mg once daily sustained release. Now, the next question is, a 9-year-old male child comes to the pediatric clinic with mother. She complains that his son, I think I can skip this question. Let's come to this. A 7-year-old boy is brought by his parents for routine checkup at the clinic. The child is in normal state of health, but is reluctant in answering the questions about his health. He is seen to be dwelling in thoughts and is looking tired. His parents complain he has been underachieving and his school academic and is underachieving in his school academics and is known to have fewer friends. His reading and writing is below compared to his age. He is amicable at home and is normally interactive with parents at home, but there are instances where he loses attention and cannot cope up with the pace of conversation. Which of the following is the right answer? Yes, absolutely. Here the answer is dyslexia, because clearly it has been mentioned that it has been underachieving in his school. School friends are low, because definitely a child with reading and writing has issues with interaction. His reading and writing is below compared to his age. Otherwise, he is amicable at home. So that means the child is developmentally normal, but his reading and academic skills are low as compared to his age. And as a result, he loses attention while talking because he cannot cope up with the sustain, because there are issues also with speaking in communication. But the major issues which we get in a child with dyslexia is definitely in reading and writing, which is compared low as per his age, which is clearly being mentioned in this child. So it fits into the criteria of dyslexia. So let's come to the next question. A 4-year-old child with ASD this is a question on risperidone. A 4-year-old child with ASD with aggressive behaviors was put on 0.25 ml of risperidone HS. The child showed initial improvement with risperidone and was on therapies for 1 to 2 months, and then suddenly started having continuous crying and spells, and there was an overall deterioration. So 4-year-old child was put on 0.25 ml for 1 to 2 months. There was initial improvement, then there was overall deterioration. The dose was increased from 0.25 to 0.5 ml. His behavior settled for next 4 to 6 months, and again there was a deterioration in behavior. So is there any explanation for this? There is an inverse relationship between the dose and response of the drug. There is a dose dependent threshold response of the drug. There is an exponential relationship between the dose and the response of the drug. None of the above. So what do you think is the right answer in this? I have discussed this question also in the group. So if they have seen that explanation, probably they might know. Okay. So here the correct answer is B. That is, there is a dose-dependent threshold response of the drug. Now, risperidone is a very, very peculiar drug which shows such typical type of threshold response in relation to the dose and response. So let's see what exactly this dose-dependent threshold response means. Now, this is risperidone has a typical individual variations in pharmacokinetics parameters, which can be attributed to several factors such as age, body weight, and genetic variations. The genetic variability in the pharmacodynamics of individuals which are with identical concentration of risperidone in plasma and tissue can still vary extensively. This means to say, if you put two child with 0.25 ml autism with the same age group, one child might benefit better, another child might not benefit at all, because depending upon the same dose and age, there are genetic variations, and there is a variation in the concentration of the plasma of risperidone and in the tissue varies extensively, and that is because of dose dependent threshold response in some individuals varying in relation to the genetics. So this has been taken from the guidelines of current neuropharmacology. So if you go into the graph B, when you started with dose 0.25 ml, there was an initial response, but after that the dose of that dose was remaining a threshold, and as a result the body gradually started responding poorly to that because a threshold level was increased. And then again, after a certain period of time, in order to attain a particular effect of that drug, you again had to increase the dose. So from 0.25 we increased to 0.5. And then again at a certain level, we get immediate response. And again, a threshold level will reach, plateau phase will reach where they will no further response. So in order to increase that dose, get the response, we again have to see. And also in our clinical practice, we have seen a lot that many a times continuously, very rarely have seen that we are able to withdraw the child from risperidone after a period of 2 to 3 years. Invariably, we have to increase the dose of the child gradually in order to maintain his behaviors once the child on risperidone. This is typically because of the dose dependent threshold response of this drug. So that is why always, my approach is always reserve this drug only in case of difficult and self-injurious behaviors where there is hitting, biting, pushing, pulling of hairs, scratching, and causing injury to others and them. Because many a time behaviors could be due to sensory, could be due to comorbid issues. So this is a typical mechanism pharmacodynamics of this drug. So the answer is B. Dose-dependent threshold response of the drug. Now let's come to the next question. A 3-year-old male child with average speech and cognitive skills. Mother complains to the doctor that he is always fidgeting in class, running, pushing, and disturbing other kids. This has increased over a period of time in school, and mother is very worried. Mother says the child is. I think we have done this. Let's move on to the next. Yeah. So this is a question on IEP. I'm just skipping this question because we are very short of time. So there's 2 questions are left, I think. So a 6-year-old male child with ASD with learning disability is assessed by a team of professionals in school as parents want to enroll him for education. So he has an ASD child with learning disability. Now parents I want to enroll my child into the school. Initially was on homeschooling. So a team of professionals assess the child. After assessing the child on academic curriculum and behavioral issues, and sensory issues, they plan to formulate an IEP for the child and inform the parents. So how would they plan to enroll the child initially in the class? Enroll in class with least restrictive environment, enroll in a class with group of 6 to 8 kids, enroll in a class with a group of 2 to 4 kids, or enroll in a class with 1:1 ratio, that is 1 teacher, 1 student. So what could be an answer you think? So he's a 6-year-old child with ASD with learning disability, and now he has been enrolled in the school, and an IEP has been formulated, and they plan to enroll the child in the class. What should be the best option in this? Okay, so all of them I mentioned answer D. Enroll in class 1:1. So first and foremost thing I want to ask, what made you think that he should be enrolled in 1:1? Do you know the ability of that child? Do we know his ability of his academic skills? Do we know anything? We have assessed on his behavioral issues. We have assessed on his sensory issues. We have assessed on learning disability. But why not it can be a 2:1? Why it is only 1:1? So the first, whenever we are formulating an IEP, on the basis of an IEP, the child has to be enrolled in a class. There are different stratifications for the enrollment in class as per the IEP, that is individualized education program. The first and foremost plan is you have to enroll a child in a class with least restrictive environment. Means you do not have to disturb the class at all. Suppose there is a class of 28 students and there is a class of 20 students and one ASD kid has been enrolled in that class. So you have just enrolled the child and you have not done any restriction for that child. Or least restrictive means you feel that 20 is not good. Let's make it 5. Let's make it remove 5 children. So you remove the 5 typical children from there. So now you enroll a child in a setting of 15 neurotypical child and 1 ASD child. So you have done the least restrictive environment. We do not want to give the child the maximum restriction. Initially, we want the child. This is what the concept of inclusive education. We always talk about inclusive education when we are giving 1:1. We are not talking about inclusive. The child has been enrolled in special education. We don't want a child in a special school. We want the child to be enrolled in inclusive. We talk about inclusive education so much. So that is the concept of IEP. Whenever we formulate an IEP, our aim is to enroll the child into an inclusive education, irrespective of his ASD, irrespective of his learning disability. So the first and foremost thing is enroll the child in the least restrictive environment. If the child is not being fit into a setting of 15 child with 1 ASD, reduce the setting. Make it 10, make it 6, then accordingly you have to reduce. So step 1 is least restrictive environment, which we known as least, L-E-A-S-T, least restrictive environment. So the first best option for this child is enroll in a class with least restrictive environment. This is the initial step. This is not the best. Probably he might not fit into that. We might require 6 to 8 kids or we might require 2 to 4. That is a later. But the initial step here is, first step would be done is least restrictive environment. So the answer is A. This is as per the IEP, and this is what they promote inclusive education. So next question again on IEP, an 8-year-old male child with severe case of learning disability studying in an inclusive setup with IEP curriculum as per the needs of the child. So the IEP school team decides to modify the IEP curriculum of the child as it has been following since last 1 year, and the child has shown significant academic improvement. So they were following an IEP since last 1 year, has shown a significant improvement. So now they decided to make a change in an IEP. So the school decides the date and time for the IEP. So the presence of whom is mandatory in an IEP meeting. So we formulate an IEP every 1 year depending upon the needs of the child in order to make the changes, maybe 6 months. So the presence of which of the following is mandatory in an IEP? Anybody wants to tell this answer? Okay. So yes, we have to remember IIP. Whenever we formulate an IIP, there are 4 important things which should be present. IIP should always compromise of the principal. It should compromise of the student if the child is more than 16 years. This is very, very important. If a child is more than 16 years, he should also be a part of an IIP. Second, a special educator and parents. But the mandatory part is parents. If the child is more than 15 years, then the mandatory participant becomes the child and the parent. You cannot ignore. It has to be both. Unless and until if the child gives an authorization letter that I am not eligible for the IIP, I am having so and so issues. So my mother will be there. I am giving the authorization letter. This is very, very important. This actually has to be followed, though it is not followed in India. But these are the international guidelines for an IIP that a child, irrespective of his ability, he should be a part of an IIP if he's more than 16 years. So here the child is 8 years, so definitely he is not involved. He's a minor, so then parents are there. But if he's more than 15 years, then the answer would have been somewhat changed. It would be parents and student, unless and until the student gives an authorization letter that parents will be part only. So the answer is parents here. So with this, I will finish today's webinar. So this was all about from my side. So this was the basket of questions which I have prepared myself, and we have discussed over a period of time in different groups. So I think we have completed well on time. So over to you, Dr. Nitin. Dr. Nitin.